detail, no, but just the overview of the nervous system, how it is organized, okay, how it is organized, so that as you study other topics, okay, then you can correlate with the nervous system, how the nervous system interacts with the other systems to coordinate the body, okay, and also when you come to learn the nervous system in detail now in next year, then now you will be able to connect what this system is, and it will be easier for you to study the nervous system in detail. Okay, so here is just an overview of the nervous system organization. So with that, of course, the nervous system, we all know that the cells that make up this system, the neurons, isn't it? So the neurons, the neural glial cells, which we did, and nerve tissue. So the nerve tissue forms the nervous system. So we're not going to waste time to discuss the neurons, the neural glial cells, and so on, which make up this system. That has been covered already. So our starting point will be the classification of the nervous system. How do we classify the nervous system? Okay, so the nervous system, as we can see from even this picture in front, we can see that we have two colors, pink and blue. So we can see that we have the brain and spinal cord painted pink, and then we can see the rest of the nerves painted blue. This gives us one form of classification of the nervous system, which is the anatomical classification. Okay, so anatomical classification. So anatomically, the nervous system consists of what and what?
Central nervous system and peripheral.
Central nervous system and peripheral nervous system. So central nervous system and peripheral nervous system. The central nervous system consists of the brain and spinal cord. Brain and spinal cord. Whereas the peripheral nervous system consists of what? The nerves, peripheral nerves, isn't it? Okay, now peripheral nerves, they are divided. We have those which come from the brain, and we have those which come from the spinal cord. So those which come from the brain, what are they called? Cranial nerves. So they are called cranial nerves. Okay, and how many are these cranial nerves?
There are 12.
There are 12.
Yes. There are 12.
There are 12?
Yes.
12 paired. Okay, so 12 paired cranial nerves. So there are 12 paired cranial nerves. Strictly speaking, that means 24. But of course, they are paired. So 12 paired cranial nerves. Okay, we'll come to that discussion. So 12 paired cranial nerves. What about the spinal nerves? How many are they? Yes, madam, there. Sorry? 31. Okay, so 31 paired spinal nerves. 31 paired spinal nerves. 31 paired spinal nerves. Again, we'll come to that discussion. For now, we are just classifying. So, yeah, so that gives us the anatomical classification. So, anatomically, the nervous system consists of CNS versus PNS. CNS being central nervous system, consisting of the brain and spinal cord, and PNS consisting of cranial nerves, 12 paired and 31 paired spinal nerves, depending on the exit point of these peripheral nerves, where they are coming from. If they come from the brain, cranial nerves. They come from the spinal cord, spinal nerves. So that is the anatomical classification. Of course, there is a a separate system of nerves, okay, which authorities have failed to either decide whether it's part of the peripheral nervous system or it's existing as an independent system. That is the enteric nervous system. Enteric nervous system, okay? So enteric nervous system. So this is a system of nerves that is found where? Yes, sir. In the gastrointestinal tract, in the GIT. So gastrointestinal tract. Okay. So again, we'll look at that system separately. Okay. So the enteric nervous system. Okay, enteric nervous system. So some textbooks will just put it separate. Some will put it like it's part of the peripheral nervous system. But yeah, so we must know that this is a system that is in the GIT, but obviously controlled by the higher centers in the brain. Okay. We look at the next way of classifying part of this nervous system is the physiological way. How can we classify physiologically? Now, specifically the peripheral nervous system. Peripheral nervous system. Okay. So, physiological classification of the peripheral nervous system. Physiological classification of the peripheral nervous system, of the PNS. Not the entire CNS, not the entire nervous system, but just the PNS. We just isolate PNS, we classify it physiologically, or functionally, if you want. So peripheral nervous system, remember anatomically we are saying that it has cranial nerves and spinal nerves. That's anatomical. Physiologically, PNS has two divisions. Physiologically, PNS has two divisions. What are these divisions? Yes, madam? Yes, so afferent division and efferent division. So afferent division and efferent division. Afferent, we can also call it
sensory.
We can also call it what? Sensory division, isn't it? Sensory division. Okay, because this is a division of the peripheral nervous system that is able to sense, okay, the surrounding, and then carry the impulses towards the CNS, towards the CNS. So hence afferent is towards. Okay, so in this case we are referring to towards the CNS. So afferent division, we can also call it sensory division. And then we have the efferent division, which is, we can also call it what? Motor division. Okay, so sensory versus motor division. Motor division, efferent meaning away from CNS, okay, towards the periphery. Okay, so for instance, if you touch a hot object like a stove, okay, immediately there will be withdrawal of your hand from the stove, okay, within seconds, without even realizing what you have done, okay. So quickly you withdraw your hand from the stove. Why? Because we have receptors in the hands, the fingers, okay, which are able to sense heat. Okay, they're able to sense heat or pain and whatever. And so these receptors will then send information towards the CNS, So there will be afferent impulses traveling through the sensory division to the CNS, okay? And then from there, there will be a reflex arc, to send information towards the effector organs, in this case the skeletal muscles, okay, the biceps brachii, to contract and flex the elbow so that you remove your hand from the object, okay, as quickly as possible. So hence we have two divisions. We have the afferent division and efferent division. Now the efferent division, we can further subclassify that one, the efferent division or motor division. Okay, how can we subclassify it?
Systematic and
Yes, is it? Yeah, behind there. Yeah, sorry, I can't get you. Okay, autonomic and somatic division. Very good. Yeah, so we have there are two subdivisions of the efferent division. Two subdivisions. We have the somatic division, somatic motor division, and we have the autonomic division. Okay, so somatic division versus autonomic division. Somatic is from the word soma, which means what?
body.
Which means
Body.
body, isn't it? To do with the body. So soma is to do with body. So somatic. And in this case, it means this motor division goes to control what? To control which structures? Skeletal muscles. Okay, so it controls skeletal muscles, and it's voluntary. Okay, remember the other one is autonomic. This one is somatic. Somatic is voluntary. Okay, whereas autonomic is involuntary. So, in other words, you can subclassify this efferent division as being voluntary division versus involuntary division. The voluntary is the somatic one, and then the involuntary, that is the autonomic. Okay, the autonomic. So somatic is to control skeletal muscles. We have done the muscle tissue. Yes, so we know the characteristic features of skeletal muscles, characteristic features of cardiac muscle, and smooth muscle. Okay, so if a question came, contrast skeletal versus cardiac, or cardiac versus skeletal, or smooth versus cardiac, you should be able to tabulate a very nice table, isn't it? Okay, showing those different features, isn't it? Yeah. So, somatic to skeletal muscles, then autonomic is to what? Yeah, to the other muscle types, the cardiac muscle, smooth muscle, as well as what? What other structures are controlled involuntarily? Okay, without control. Yes.
Internal body.
Glands. Yes. So glands. Okay, you can't tell your sweat glands to start sweating right now. You can't. Isn't it?
Yeah.
They act by involuntary control. Okay, involuntary. So cardiac muscle, smooth muscle. Okay, those are involuntary muscles. You can't say, once you have swallowed that big bolus of food, when it reaches the esophagus, you can't say, stop there, don't go down to the stomach. You can't, isn't it? So it will continue going until it reaches the stomach. The same with the heart. You can't tell your heart to stop beating, okay? You can't.
But we do pause.
So those are the involuntary structures. So involuntary to control to the cardiac muscle, the heart, to smooth muscle, as well as glands, various glands in the body. Now this autonomic system, we can further subclassify it, isn't it?
Mm-hmm.
Yes, what is the subdivisions? Parasympathetic versus sympathetic, isn't it? So parasympathetic versus sympathetic system, okay, nervous system. So these two divisions, they act in opposite to each other. Okay, they act in opposite to each other. They are like acting like a tug of war. One is pulling this side, the other one is pulling the opposite direction. Okay, so parasympathetic versus sympathetic system. At rest, like you are right now, which system is in action?
Parasympathetic.
Parasympathetic, isn't it? So parasympathetic is acting right now. You are relaxed, you are listening to the lecture, so the moment you say, I have papers in my car for test 1, you see how people start. The sympathetic system will be activated. Yeah, start sweating. Some will start going to the toilet to empty the blood and so on. Yeah, so at rest it is parasympathetic, but when you are in fear or you are frightened, okay, or you want to fight and so on, fight back, the sympathetic system kicks in. Okay, if there was a snake here, you see how people start jumping. Some even off the windows, out through the windows and so on. Okay, because it's a response. The sympathetic system has been activated. Either you fight back or you run away because you don't have the energy to fight. Isn't it? Yeah. And so this system gives you energy. Okay? You start breathing more, the heart races more, and so on and so forth. Okay? Glucose is released from the cells so that you have energy. Yeah, so anyway, that is the autonomic nervous system. So autonomic nervous system consists of parasympathetic versus sympathetic nervous system. Again, we'll come to that, to the details of the two systems separately. Okay? But maybe I can mention just now that the parasympathetic system, the parasympathetic versus sympathetic system, we have got specific nerves. We have got specific nerves which have this function. Okay, we have specific nerves or regions of the CNS which have these functions. Okay, so for instance, parasympathetic system. The parasympathetic system from the spinal cord, we have which segments? Parasympathetic. From the spinal cord. Which segments? Where is the origin of the parasympathetic system from the spinal cord? Yes, sir. Come again? Foramen magnum. No. From the spinal cord. Foramen magnum is an opening through which the spinal cord exits the skull. So, from the spinal cord is basically S2 to S4. S2 to S4 from the spinal cord. And then we have also cranial nerves, which have parasympathetic function. Okay, cranial nerves, number what and what and what? Cranial nerves?
C3, C7.
3,
C9,
yes, good.
And C10.
Sorry? 10, before 10?
7.
Before 10, which other?
7.
Cranial nerves 3, 7,
9.
9, and 10. Okay, cranial nerves 3, 7, 9, and 10. Okay, so 3, 7, 9, and 10. Those cranial nerves plus the sacral segments of the spinal cord S2 to S4, they make up what we call the cranial-sacral outflow. Cranial-sacral outflow, which forms the parasympathetic system. So it's the cranial-sacral outflow. Cranial nerves 3, 7, 9, and 10 plus spinal segments S2 to S4 make up the parasympathetic system. Whereas the sympathetic Sympathetic is what? Yes, madam? Come again? Thoracolumbar outflow. Thoracolumbar outflow from meaning which segments?
Thorax.
T1 to
L2.
L2. Okay, T1 to L2 segments. Okay, that's the origin of the sympathetic outflow. Origin of the sympathetic outflow. So you find such questions in the MCQs and so on. So sympathetic outflow is from T1 to L2. Okay, T1 to L2. Thoracolumbar outflow. Thoracolumbar outflow. Okay, we'll still come back to these details. For now, let me try to show the pictures.
7.
So this we did under nerve tissue. Okay, this table is familiar with you. Okay, so that's okay. So you can see another picture. Another picture to show the topography of the nervous system.
This one.
Topography of the nervous system. Okay, so we can see the central nervous system. Okay, the central nervous system, brain and spinal cord. So there's a circle there for the central nervous system, brain and spinal cord. And then we have the peripheral nervous system, which have two divisions, the sensory division or afferent division, and then we have the motor division. The motor division, and then we can see that sensory is able to get information from the surrounding, including even internal structures. So signals from external environment, signals from skin, tendons, and muscles, and signals from internal organs. Okay, so sensory nerve fibers, take impulses to the CNS for interpretation and so on. And then the motor, we have already highlighted to say, consists of the somatic division to control skeletal muscle, as well as autonomic division to control smooth muscles, cardiac muscle, and glands. And it consists of two subdivisions, parasympathetic and sympathetic nervous system. Okay, we can see again from the picture. Okay, we can see the brain there. We can see the spinal cord. So this makes up the CNS, and then we can see the peripheral nervous system. Okay, including the sympathetic tracts and so on. Okay, so like we said, sympathetic outflow, thoracolumbar, T1 to L2, and parasympathetic craniosacral, 3, 7, 9, and 10 cranial nerves, and then S2 to S4 spinal segments. Cranial nerve number 3 is what? Cranial nerve number 3, those who are studying in advance.
Oculomotor.
Cranial nerve number 3? We don't know it. Oh, yes, madam. It's called what? Oculomotor nerve, isn't it? Yes, good. Excellent. So it's called oculomotor nerve. Oculomotor nerve. I come into the cranial nerves. Cranial nerve number 7. Number 7. So these numbers are like your computer numbers. Huh? So they are like your computer numbers. Meaning that there is no way your computer number today, tomorrow it changes. It becomes another number. No. Okay, the way you have been given those computer numbers is throughout till you graduate. Okay, so when we stick results with computer numbers only, definitely you'll be able to know that this is me. Yeah. Isn't it? Yes. That's the same way these cranial nerves are. So there's no way oculomotor nerve tomorrow becomes cranial nerve number 10. No. So it will always be cranial nerve number 3. Cranial nerve number 7. Yes, sir.
Facial nerve.
Facial nerve. Okay, facial nerve. To control the face and so on. So facial nerve. Okay. Number 9. Cranial nerve number 9. Glossopharyngeal. Glossopharyngeal nerve. And cranial nerve number 10. Vagus nerve. Isn't it? Vagus. The more common, well-known cranial nerve, vagus. Okay, so that's that. We have this topography again. We have already highlighted this. Okay, so we can see the anatomical classification, of the nervous system. Okay, so nervous system, peripheral, CNS, efferent, afferent. Efferent, autonomic, which is para and sympathetic, and then somatic system. We can see the enteric nervous system is independent. It's separate there for the GIT. Okay, this is other pictures to show the CNS, the brain, spinal cord, and then PNS to show the peripheral nerves. So, having classified our nervous system anatomically, physiologically, we now go into the details of, not really details, but overview of CNS. Overview of CNS, to just get the overview of CNS, central nervous system. So remember we said CNS is the brain and spinal cord. So we're going to start with the brain. We just see how the brain is arranged. Okay, how the brain is arranged. So anatomically, the brain is divided into 3 parts. We have the forebrain, we have the midbrain, and hindbrain. So forebrain, midbrain, hindbrain. Okay, it might be difficult for you to appreciate the orientation of these parts, to say forebrain, midbrain, and hindbrain. Okay, but the naming of these parts, it was based on the fetal position. When you were still in the uterus, okay, of your mother. Okay, so do we know the fetal position? Do we know how the baby is oriented inside the uterus? Or the other way is if you look at a four-limbed, not limbed, but an animal that walks on 4 limbs, an animal that walks on 4 limbs, for instance, a cow, a goat, a dog, okay? The orientation is different from a human being who walks on 2 limbs, isn't it? Okay? Because the head is oriented upright in a human being, whereas in the other animals, the brain is horizontal. Okay, orientation is horizontal. And so that horizontal orientation is what matches with the classification of forebrain, midbrain, and hindbrain. Okay, it matches because the brain is like that. And so forebrain is in front, then we have the midbrain, and we have the hindbrain behind. But in a human being, after birth, okay, the baby starts to sit, okay, stand upright, and so the brain orientation becomes like this, okay. So from fetal position like that to a straight orientation. So what was forebrain what was forebrain becomes on top, and then midbrain in the middle, then hindbrain. Have you seen? So it's not like forebrain is near the eyes, so to say, here, then midbrain here, then hindbrain there. No. It's not that orientation. So in a human being, forebrain is up, and then midbrain, and then hindbrain. Okay? So you just compare with an animal that walks on four limbs, then you get the proper orientation. Now the forebrain, embryologically, the forebrain is called the prosencephalon. The midbrain is the mesencephalon, and the hindbrain is the rhombencephalon. Okay, so those are the terminologies which you need to be familiar with. Embryological terms of the forebrain is the prosencephalon, and then midbrain is the mesencephalon, and hindbrain is the rhombencephalon. Okay, so that's that. So we need to be familiar with these terms. So remember, here we are just looking at an overview, okay, of the brain. We're not going to go into details, just an overview. Now, when you look at the forebrain, okay, the forebrain itself, or the prosencephalon, consists of what we call the telencephalon and the diencephalon. Okay? Telencephalon and diencephalon. Now the telencephalon, that's basically the cerebrum. Okay, the cerebrum. This picture is showing the cerebrum, one hemisphere of the cerebrum. Okay, the cerebrum has two hemispheres, left and right, cerebral hemispheres, joined together at a structure we call the corpus callosum. Okay, so each cerebral hemisphere is divided, or rather it's not smooth. It's not smooth, as we can see from this picture. It has grooves and elevations. And then it is divided into lobes. We can see the colors. So it has, for instance, the frontal lobe. We can see there in red. Then we have the parietal lobe. We have the temporal lobe and the occipital lobe. The naming of these lobes, is according to the bone which is adjacent to that particular part. Okay, you have done the skeleton, right? Yes, and so we know the skull and the various bones of the skull. So if we say parietal bone, we know where it is. Occipital bone, temporal bone, frontal bone. Okay. So the naming of the lobes is according to the bone adjacent to that part. And so the frontal lobe is because we have a frontal bone which is there, and then parietal, temporal, occipital. Okay, but what I wanted to emphasize are these elevations and depressions. The elevations and depressions. These elevations and depressions, they are important because of what? Why should they be there? Why not have a smooth surface of the cerebrum? Why have these bumps? Exactly, to increase the surface area of the cerebrum, isn't it? To increase the surface area of the cerebrum. Okay? That A4 size paper that you have, if you fold it, okay, you are going to create a very small paper, okay? If you fold it like that, just that I don't have a paper. Someone was, so that I can just illustrate what I mean. Okay, so if you get this paper, for instance, okay, I can decide to fold it several times. Have you seen? So I can decide to fold it several times. Okay, like that. And it means I have basically increased the surface area. If a space is a small space where I want more papers to be accommodated, I can just fold them several times like this and pack them nicely like that. When I spread, it goes back. It means now you have a longer paper, isn't it? Yeah, so that's exactly what the cerebrum, these gyri and sulci, we call them gyri elevations, sulci depressions. So the presence of gyri and sulci increases the surface area of the cerebrum to accommodate more neurons, okay? Imagine trillions of neurons are in the cerebrum. If the cerebrum was smooth like that, the size of the brain would be too big, more like occupying this entire room. Okay? If the surface was to be smooth and be able to accommodate all the neurons in the cerebrum. It will mean you need all this space. Now imagine having such a brain on top of you. Okay? So that's why we have these gyri and sulci in order to accommodate them in a small brain size. Okay? So remember, we are talking about the divisions. So prosencephalon, the telencephalon or cerebrum, okay, and the diencephalon. The diencephalon consists of three major parts: the hypothalamus, thalamus, and epithalamus. Okay, so those thalamus, hypothalamus, and epithalamus. Okay, so you should know the components of the diencephalon. Which of the following is not a component of the diencephalon? You should know which one should not be there, isn't it? Okay. Coming to the midbrain, the midbrain is divided as well. The midbrain has 4 parts. If you look at the midbrain, so it has 4 parts, and from anterior to posterior, we have the crus cerebri, okay, crus cerebri, the substantia nigra, and tegmentum and tectum, okay, tegmentum and tectum. Now the crus cerebri, those are like the feet for the cerebrum, the feet for the cerebrum onto the midbrain. So the midbrain is connected to the cerebrum through these crus cerebri, okay, through the crus cerebri, okay. They are like the feet. Crus means foot, okay. Substantia nigra, it's named substantia nigra, of course, because of its appearance, okay. When you stain the midbrain, the substantia nigra appears black, okay, and so it's named substantia nigra. And then tegmentum is the part behind the substantia nigra, but in front of the cerebral aqueduct of Sylvius. And then we have tectum, which has 4 structures: 2 superior coriculi and 2 inferior coriculi. Okay, they make up the tectum. The inferior coriculi have pathways, the pathways to the ear. The superior coriculi have pathways to the eyes. Okay, so superior to the eyes, inferior to the ears. Okay, so they are collectively termed corpora quadrigemina. Hindbrain, the rhomboencephalon. The rhomboencephalon consists of the medulla oblongata, the pons, and cerebellum. Okay, cerebellum, not cerebrum, but cerebellum. Okay, cerebellum. Now the pons and the cerebellum in embryology, collectively they are referred to as the metencephalon. Metencephalon. Whereas the medulla oblongata is the myencephalon. Myencephalon. Okay, so again, be familiar with the embryological terms because when it comes to embryology, we'll be using these embryological terms to describe these different parts of the brain. So this is the overview of the brain in terms of the various parts. Okay. Now, when you look at the brain arrangement, you find that it has more like this cerebrum. It's like a shape of an umbrella, where you have a broader part on top, and then you have a stalk. Okay. So the stalk of the brain is what we call the brainstem. The stalk of the brain is what we call the brainstem, and this brainstem has got how many parts? 3 parts. Okay, what are these parts? What are the parts of the brainstem? So out of these parts, which ones make up the brainstem? Yes, madam. Medulla oblongata is one of them, and is the last part of the brainstem. It's the bottommost part of the brainstem. The other one, the pons in the middle of the brainstem. The pons. The one on top is what? The midbrain. Okay, so again, you need to know the arrangements. Okay, because a question can be asked: which of the following parts? Which of the following parts of the brainstem from superior to inferior? Okay, so we have the midbrain, the pons, and medulla oblongata. So you can see how questions can twist. So instead of saying which of the following is a part of the brainstem, or which of the following is not a part of the brainstem, we can just give you the parts of the brainstem and ask you to, to orient them from top to bottom. Okay. So that's that. Now the brainstem is very important because that's where the cranial nerves, most of the cranial nerves come from. And if one has a brainstem death, then that means that individual or patient is dead. Okay, despite the individual heart still beating, the heart can still be beating, the oxygen and so on, breathing being provided by a machine, a ventilator, okay, and you can continue feeding that patient using a nasogastric tube, okay, to take food to the stomach. So despite you feeding that patient, making him or her breathe through the ventilator, the heart is still pumping. But if the brainstem is gone, then that is death. Okay, that is death. And all you need to do is to convince relatives to accept the situation so that you can disconnect the machine. Okay? Yes. So you just need to counsel the relatives that we have reached the end of life, despite the heart still beating, okay, being fed, machine breathing for the patient is gone. Okay, so you allow them to pass through those stages of grief, okay, from now to acceptance. We know them. Are we doing in psychology? Yes. Okay. So we know the stages. Huh? Yeah. So once they accept, then you disconnect. Don't disconnect just because you are a medical doctor, you disconnect. You'll be sued. You'll be sued, and your license will be revoked. Okay? HPCZ is going to come, revoke your license, you stop practicing medicine, and you go back to the village where you came from. All right, let's look at this picture. This picture is just illustrating the ventricular system in the brain. Okay, the ventricular system, the ventricles. The brain also has ventricles. Just like we have ventricles in the heart, we have ventricles in the brain. Okay, and we can see these ventricles. They are basically cavities. They are cavities or spaces within the brain. And we can see there are three. The lateral ventricle, the third ventricle, and the fourth ventricle. Okay, so those are the ventricles. The largest are the lateral ventricles. So we have two lateral ventricles, then we have the third ventricle, and then we have the fourth ventricle. You need to know where to find the lateral ventricles, where to find the third ventricle, and fourth ventricle. So the lateral ventricles, they are found in the cerebrum. They are found in the cerebrum. Whereas the third is found in the diencephalon. That one for the thalamus, hypothalamus, and epithalamus. And then we can see the fourth ventricle is found in the pons and medulla oblongata. The roof of the fourth ventricle is provided by the cerebellum. The roof is the cerebellum. Okay, so that is the ventricles of the brain. Okay, and they are connected. They are connected. We can see the lateral ventricles. They are connected by the interventricular foramina. Foramina is plural. We have two. We have one here. The other one is there. So interventricular foramina of Monroe, and then we have the cerebral aqueduct of Sylvius, connecting the third to the fourth. And then we can see from the fourth, there's a connection to the spinal cord through the central canal, but also, just that not shown here, we have holes, three holes or apertures, which allow the fluid within this system to go to the subarachnoid space. Okay, so we have the foramen of Majendi, foramina of Lushka. Okay, but for now, know those. Okay. Now, what is the importance of knowing this ventricular system? What is the importance of knowing this ventricular system? You need to know it because the production, flow, and drainage of this fluid. Which fluid is this? Cerebrospinal fluid. Okay, so its production, flow, and drainage is based on this system. Okay, cerebrospinal fluid. Okay, remember from nerve tissue, which cells secrete CSF? Which cells? Ependymal cells. Ependymal cells. So ependymal cells, they line the ventricular system. They line the ventricular system. So we find the ependymal cells lining this system. The entire ventricular system is lined by ependymal cells, which form like an epithelium called the choroid plexus. Okay, called choroid plexus. So we find choroid plexus in the lateral ventricles, third ventricle, and fourth ventricle. Majority of the CSF comes from these big ones, the lateral ventricles. That's where CSF comes from, majority of it. But of course, the third and the fourth, they also produce CSF, but most of the CSF comes from the lateral ventricles because they are bigger compared to the others. And so CSF will come from the lateral ventricles, pass to the third through these interventricular foramina of Monroe, from third to fourth through the cerebral aqueduct, and then from the fourth goes to the subarachnoid space. okay, including the lumbar space at the back there, the lumbar space where we access CSF in lumbar puncture, either for diagnostic or therapeutic purposes. Okay, so the CSF, now this CSF, if it is blocked, for instance, if the flow is blocked, or maybe the production is excess, or maybe the drainage is blocked, okay, it means the CSF will accumulate in one or two of these ventricular, the ventricles. Imagine there is a blockage, complete blockage at the cerebral aqueduct. Then it means the CSF which is forming in the lateral ventricles will accumulate, and also going to the third will accumulate. So the third and the lateral ventricles will dilate, isn't it? Whereas the fourth will not dilate. Okay? And because of that dilatation of the ventricles, okay, they continue pushing the brain matter. Okay, the yellow part is the brain matter. So the brain matter will be pushed to the periphery, okay, towards the skull bone. And if it's a child whose fontanelles are not yet closed, we know the fontanelles? Yes. So if the fontanelles are not yet closed, the sutures are not yet fused, okay, it means that the skull will allow expansion of the brain. Okay, and so you find this a child with hydrocephalus with an enlarged head. Okay, enlarged head, okay, because there is basically accumulation of CSF in the ventricular system. Okay, so you hear of in layman, they will say, no, mwana ina manzi mu brain. Okay, it's this condition, okay, where you have blockage of CSF flow, okay, or accumulation of CSF flow because of drainage problems or too much production, either communicating or non-communicating hydrocephalus. Now, if it's like that in a child who is less than 18 months, okay, because of this allowance of expansion of the brain, what do you think will happen to the pressures if you compare a child under the age of 18 months and someone whose fontanelles are closed? What happens to the pressure inside the brain? The intracranial pressure. If you compare in a child less than 18 and someone above 18 months, which pressure will be more compared to the other one? Sorry? An adult, isn't it? Yes, because an adult, you can also have hydrocephalus. You can also have hydrocephalus. The only difference is that your fontanelles are closed, your sutures are fused, so the skull will not enlarge. But the ventricles will dilate like that. But this, because of the same volume, the volume is not increasing to reduce the pressure, isn't it? So it means you are going to experience severe headaches, which cannot even be, cannot be controlled by standard medicine, okay, painkillers and so on, okay. So every day you'll be complaining of headaches. Maybe it's hydrocephalus inside.
I have a question. Is there a way to safely drain the accumulated?
Yeah, a way to?
Safely drain.
To drain the excess fluid. Yes, so that's part of management of hydrocephalus. So for some of you who have seen babies with hydrocephalus, you will see that sometimes we put a shunt from the lateral ventricle. Okay, a catheter is running under the skin, from there, under the skin, and then it comes to the abdomen. Okay, that's why we press it. So that the CSF being produced in the lateral ventricles drains through this catheter into the peritoneal cavity. Okay, so it mixes with the peritoneal fluid in the abdomen. We do that. And that reminds me of one night when I was on call. This clinical officer was very, very surprised. And he called me in the middle of the night, 0000, 24 hours. Just, doctor, this patient, this child brought by the mother, I can palpate something like a code, like I don't know.
Something like I don't
The
know.
mother doesn't know also. Something dangerous in the body. And that's why they have come to the hospital. But what do you mean? No, just come. I think you appreciate when you come. So I went there and only to find it's a patient with hydrocephalus with a VPS shunt, ventricular peritoneal shunt. Okay, shunt pressed catheter running through the skin into the abdomen. Okay. Then I said, these are the students who were missing in classes. Yes, because someone could have made it that, no, this is a patient with hydrocephalus and the VPS shunt inserted, passing under the skin. Okay, so it shouldn't be a surprise, is it? Yeah. All right, so that's that. Yes, ma'am. Instead of letting it out of the body. No, it don't look good. Imagine you put a catheter and then this fluid is trickling. That's number one. But number two is that because of infection, imagine you expose the tube outside the body. Okay, it means bacteria and so on in the environment will come to the tube, then follow the tube and go and infect the brain. Okay, so meningoencephalitis can set in. Okay, so that's why we put it in the, and why we put it in the abdomen, because we can use a longer tube that a child can grow with. Okay, because remember the child keeps growing. So if you put this tube, we can shunt it in the heart, we can shunt it in the lumbar space, we can shunt it in the pleural spaces, but we usually use the abdomen because you can use a longer tube which the patient can grow with, so that it might take 2-3 years for you to change it. Okay, if you use a shorter one in the heart, for instance, it means from now and again you need to be changing. Take back the patient to theater, change and so on.
Where's the camera?
What is causing?
It's focused.
Oh, the blockages. Yeah, so there are various causes. Of course, we are not learning hydrocephalus, so I wanted to skip and move on. But anyway, for your own information, so there are a number of causes. Okay, there are a number of causes of blockages. What do you think? What could be some of the causes of hydrocephalus? So remember we said that any disturbance in the production, flow and drainage of this CSF, you end up having hydrocephalus. So what could be the causes? For instance, at production site, it means there's too much CSF than usual. So you can have malignancy, you can have cancer of the choroid plexus, releasing too much fluid into the ventricles. That's a possibility. You can have blockage by a space-occupying lesion in the brain. Any space-occupying lesion, what we call space-occupying lesion. Let's say you have a tumor in the brain, okay, even away from this system, or maybe you have TB of the brain, and then this TB develops an abscess. There's an abscess pass correction which keeps distending like that. It can compress this system. So anything occupying space which is going to block or to compress on this system, causing blockage. Okay, tumor, calcifications. Okay, some can be caused by what we call touch infections. Okay, congenital infections. Okay, like toxoplasma, toxoplasmosis, rubella, CMV, and so on. Those can cause blockages in these systems. Okay, you can have cerebral aqueduct stenosis or atresia. Someone can be born with a narrow cerebral aqueduct, very narrow cerebral aqueduct, or even completely there is no lumen in the cerebral aqueduct. Such children are there, okay, usually X-linked, okay.
How is it maintained? Because those are just
Yes. So there's drainage. There's a drainage point where this CSF goes. So we have what we call the arachnoid granulations. Arachnoid granulations, extensions of arachnoid matter which pierce dura mater in the superior sagittal sinus. That's where the drainage is for the CSF. So some babies can be born minus these arachnoid granulations. And so if there's absence of arachnoid granulations which allow drainage, then it means there will be no drainage and the CSF will continue accumulating in this system, causing hydrocephalus. Okay? So that's another point. So remember I said the disturbance in production, disturbance in flow, or disturbance in drainage. Okay? Some babies can be born with what we call malformations, such as Dandy Walker malformation, Arnold-Chiari malformation, which will cause the hydrocephalus. Okay? So, but anyway, we are not discussing hydrocephalus. Let's stick to our anatomy. So let's go back. Yeah, so appreciate these ventricles, know where they are located, and also know the flow, how the flow of CSF will happen, and of course applied anatomy, hydrocephalus, know what this condition is, just knowing that if something goes wrong with the flow, drainage and so on, you can end up having hydrocephalus. Okay, so this is a picture to illustrate the brain. Okay, again, just these different parts. The cerebral hemisphere here highlighted. Okay, we can see the part of the cerebellum. Okay, we can see the bones, medulla. This is lateral view. Sagittal view. Okay, we can see the various brain parts. Okay, the midbrain is there. We can see the bones. We can see the medulla oblongata. Okay, what do you think this is? What is this? Pituitary gland, isn't it?
Yes.
This is a pituitary gland connected to the hypothalamus, okay, via the pituitary stalk. Okay, via the pituitary stalk. Okay, so this is the pituitary gland. Okay, so we can see how the pituitary gland is strategically positioned to the hypothalamus. Okay, because the nervous system can communicate with the endocrine system at this junction. Okay, so that it coordinates the entire body. These two systems, the nervous system and the endocrine system, coordinate other systems in the body, isn't it? And that connection point is right here, where the hypothalamus is connected to the pituitary gland. Okay, we can see the cerebellum, okay, and the thalamus and so on. Yeah, so that's just basically an overview of the brain. Spinal cord. The spinal cord is the lower elongated cylindrical part of the CNS. Okay, we can see this is the spinal cord. So the CNS is broader where the brain is and narrower where the spinal cord is. So it's the narrower part of the CNS makes the spinal cord. Okay, and you can see that the spinal cord exits the skull via the foramen magnum. Okay, via the foramen magnum, and passes into the vertebral canal of the vertebral column, isn't it? Okay. We need to know the relationship of the spinal cord with the vertebral canal rather the vertebral column, okay, that initially during development, these two structures were of equal length. Initially, when they were just starting to develop, they were initially of equal length. But with time, as time passed by, the vertebral column accelerated in terms of growth and left the spinal cord behind. Okay, behind, like that. And the evidence is there. What is the evidence to show that the spinal cord and the vertebral column initially were of equal length? What is the evidence? The evidence is by a thread of pia mater, the thread of pia mater which extends from the conus medullaris, which we call phylum terminale. Okay, phylum terminale. So phylum terminale is a continuation of pia mater, which goes all the way to the coccyx. Okay, all the way to the coccyx. So that is evidence enough to show that these two structures were of equal length. In fact, again, we can see the evidence when we compare the termination of the spinal cord in a newborn and the termination of the spinal cord in an adult. At what level of the vertebral column in a newborn is the termination of the spinal cord in the newborn? In the newborn, the spinal cord terminates at what level? Yes, sir.
Number 1 or number 2?
That's for the adults. That's for the adults. In the newborn, number 3, isn't it? So L3. Okay, so in the newborn, the spinal cord terminates at L3 level, whereas in an adult, it's higher up at the disc between L1 and L2 vertebrae. Disc between L1 and L2 vertebrae. So we can see that in the newborn it's lower down, in the adult it's higher. It means that this is a child who has grown into an adult, and so the vertebral column has further accelerated in growth, leaving the spinal cord behind. Okay? Behind. So when you look at the spinal nerves, you find that sometimes it might be difficult for you to appreciate or rather to understand why we have, for instance, let's go to the, so why, for instance, we have such kind of an arrangement, what we call dermatomes. Okay, you can see that you have S1 here. Okay, S1 should be up there, but it's in the feet. Okay, L5. Okay, is in. L4 is there. L3 is there. So when you go to the vertebral column with the spinal cord, you find that, for instance, the thoracic vertebrae, you have the origin is up there, but where it comes to exit is down. Okay, the same thing here. You have for the coccyx, for instance, the coccyx is up there. Why not come out from there? Direct. Why not direct from there? It's because these they were originally came out from lower down there, when the spinal cord was of equal length with the vertebral column. So the cord has been left behind, but the nerves, they still exit at the original sites where they were exiting initially. We get the point, huh? Yeah, so it's like the spinal cord has been pulled up, okay? But the spinal nerves, they are exiting at the original sites where they are supposed to exit the body, okay? So that's that. Now the spinal cord, another feature we need, so know the termination of the spinal cord. In an adult versus newborn, you're supposed to know where the termination is. because this is important in clinical practice to know the landmark for either spinal anesthesia or for lumbar puncture. Okay? For lumbar puncture. If you want to do lumbar puncture to correct CSF, which are the anatomical landmarks that you need to know in order for you to correct CSF from the lumbar space. The lumbar space is this space here, the space of the subarachnoid fluid. Do I have, yeah. So you can see that the spinal cord is ending here. We can see the filum terminale, this black line. We can see the arrangement of the spinal nerves like a tail of a horse, which we call what? Coda equina. Coda equina. Okay? Coda equina nerves. So these are coda equina nerves. Okay? So we can see that dura mater is coming all the way down to S2, and the spinal cord is up. So there is a space between the spinal cord and dura mater. This space is what we call lumbar space or lumbar system. Okay, and it is in this lumbar system where we collect CSF during lumbar puncture. Okay, so lumbar puncture, spinal anesthesia is the same procedure, only that in spinal anesthesia you are injecting the drug into that space so that that drug paralyzes the nerves, these coda equina nerves. So in spinal anesthesia, you are injecting the drug into the lumbar space so that these nerves are paralyzed. And remember that these nerves are the ones which supply the body from umbilicus going down. You get the point? So the coda equina nerve supplies the part of the body from the umbilical region downwards. So when they put spinal anesthesia there, the body will be paralyzed from the umbilicus going down. And so you can be able to do any procedure below the umbilicus, from cesarean section to amputation of the foot. You can do, because the body going down is paralyzed. Meanwhile, you are discussing with the patient, because the upper part of the body is not paralyzed. You get the point? So you can be discussing. Okay, as you do your cesarean section and so on, the baby is out, you will show the mother and so on. You chat, you can chat with the patient. Okay, unlike general anesthesia where you have to put the patient to sleep. So with spinal anesthesia you are injecting, but with lumbar puncture you are collecting the CSF and taking to the lab. Okay, taking to the lab. Okay, good. So what are the anatomical landmarks? The anatomical landmarks. So for you to do lumbar puncture, you need to either make the patient sit like that. Okay, we can see there, patient sits and then bends forward. Okay, flexes the trunk forward. Why do this? Because we want the intervertebral spaces to open up. We want the spaces to open up. Okay, so the shoulders are relaxed like that. Then you make the patient bend forward so that the intervertebral spaces open up. You palpate for L4 vertebra. How do you palpate for L4 vertebra? Is by palpating the iliac tubercles. We have heard of iliac tubercles?
Yes.
Yes, from the skeleton. So iliac tubercles. So you palpate the iliac tubercles, basically the highest points on the ilium. Okay? Then you go behind. At that level, you'll be at L4. Then it means once you're at L4, if you go up, the vertebra above will be L3, the vertebra below will be L5, isn't it? So remember that the spinal cord in an adult ends at L1, L2, somewhere there. And so it means at that level, you can safely do lumbar puncture. You can puncture in between the interspace L3, L4, or you can perform the lumbar puncture in the interspace L4, L5. Don't prick through L4 because L4 is a bone, isn't it? So make sure you prick in the space, in the interspaces. So either L3, L4 or L4, L5. That's where you do lumbar puncture. Those are the anatomical landmarks for lumbar puncture. If you are starting for the first time, better to do below L4. Use L4, L5. Okay, but as you gain experience, you can now go L4, L3. Okay, so that is in the adult. In the newborn, because the spinal cord ends at L3, you are not going to do your lumbar puncture between L3 and L4. You are going to do the lumbar puncture at L4, L5 interspace. Isn't it? In the newborn, because you know that the spinal cord is at L3 termination. Okay? Why are you avoiding the spinal cord? Because if you prick through the spinal cord, you are going to cause spinal injury. Okay? Spinal injury, which will be catastrophic, and the patient can be paralyzed. Okay? So imagine after doing the lumbar puncture, and then the patient is unable to walk. It's paralyzed. Both legs are paralyzed. Yeah, because you haven't done a good job. Okay, you have basically missed the anatomical landmarks. And you can't do between L5 and S1. You can't do between L5 and S1 because there is no enough space between the lumbar vertebrae and the sacrum. There is no enough space there. And the sacrum, remember, is a fused structure, isn't it? So you can't do between, let's say, S1, S2, or S2, L3. You can't because the sacrum is fused. And that's why sometimes it's considered as one bone, okay, with fused vertebrae. For you to arrive at 206 bones, the sacrum is considered as one bone. Okay. Yeah, so know the anatomical landmarks for lumbar puncture. But from that, something to highlight here is basically the tracts. Just to highlight that in the spinal cord, we have gray matter and white matter. The gray matter is in the center. We can see the gray matter. The white matter is in the peripheral. And the gray matter is basically cell bodies. Okay, cell bodies. So cell bodies in the spinal cord, they are found in this gray matter in the middle of the cord. Whereas the processes, dendrites and axons, they form the white matter. Now the white matter is divided into tracts. Some ascend, some descend. The ascending tracts, those are sensory. The descending, they are motor. Okay, so you can see from here we have various descending tracts and ascending tracts. But we're not going to go into the details of these tracts. For now, just appreciate that in the spinal cord, we have ascending tracts which are sensory, descending tracts which are motor. Then when you do physiology and anatomy in fourth year, you now learn these individual tracts, what they carry and their functions. Yes, for those who make it. All right. So that is the CNS. Now we go to the peripheral nervous system. People are surprised. We started by classifying, so now we have done the CNS. From CNS, we are going to PNS. From PNS, we end with enteric nervous system. So PNS, we already know, oh, there's a heart.
Where do people get questions?
The drug. Yes, so the drug is similar, but of course in the spinal anesthesia we use bupivacaine. We use bupivacaine instead of lidocaine. So that one for circumcision and for local anesthesia, we use lignocaine. That's lignocaine or lidocaine. But for this one, we need bupivacaine because it's heavier than lidocaine. And actually, we can even make it more heavy by adding dextrose. So why do we want it to be heavy? Because we want the medication to just be down here, not up. That's why even the table where you place the patient should be slightly tilted upwards. The head should be up, then the bottom part, so it should slant like that at an angle. Okay? Don't make it flat. Because if you make it flat or it goes down, it goes the legs up, the head down, the drug which is here will go up towards the brain. You get the point? Now, as it goes up towards the brain, it means it's going to paralyze nerves which are up. Okay, imagine such a thing happening, and it has happened before, where now the CSF now, the drug now goes up, and it paralyzes all these nerves. A high spinal, we call it a high spinal. So a high spinal, you end up paralyzing nerves which supply respiratory muscles, okay, including the phrenic nerve which supplies the diaphragm, to be paralyzed. Now imagine such a thing happening. It means this patient will stop breathing nicely, isn't it? So stop breathing, the cardiovascular system will be affected and so on, and the patient will die. Those are the patients you hear, no, went for a cesarean section, and then something happened there, patient died. Why? Because some of the things could be an accident, can happen. And no wonder we emphasize to say, especially in obstetrics, we emphasize to say a cesarean section is not the best option for delivery. Delivery is vaginal delivery, okay? That's the first choice. Unless there are contraindications or there are obstetric indications for a Caesar. Because a Caesar is 5 or 10 times more risky of a patient dying or having morbidity afterwards, okay, compared to vaginal delivery. And so the patient needs to know what might happen before the actual operation, just anesthesia. Just from anesthesia, you can have an anesthetic accident and so on. Okay, at the time of operation, you can have severe bleeding. Afterwards, okay, again, you'll be you can't walk immediately. You'll be bedridden a bit and so on, and that is the risk. You can develop a clot in the veins, which can go to the lungs and so on. So there are a number of morbidities. There was a hand here. Yes. Come again? Yes. It's professional negligence. So you can lose your license if it so happens that, if it so happens that this information is known and they come, they review what happened. You lose your license. That's why when you are working, there are specific individuals with specific functions. If you are a surgeon, you stick to being a surgeon. Your job is to cut and do the job and come out. Anesthesia, we should have a different person doing anesthesia, specifically for anesthesia. Okay? Theater nurses, just like that. So each has a role to play. So when you go out there in the villages, Shangombo, what? Don't become a jack of all trades, where now you give anesthesia, you even cut, and so on. Because imagine you give anesthesia to this patient, spinal anesthesia, and then you go and wash your hands so that you come and cut. Then you find the tape was tilted and the patient is gone. That's happened. Yes. Sorry? where the CSF is coming from. That's just, or you mean the space. That's the lumbar space. The lumbar space or lumbar system. Lumbar system. Okay? Let's move on. So, we come to PNS. PNS just, highlighting the various cranial nerves. Remember we mentioned to say there are 12 pairs of cranial nerves. There are 12 pairs of cranial nerves. So everyone needs to know the various cranial nerves. Okay? The various cranial nerves. If we say cranial nerve number 12, you should be able to know what that cranial nerve is. Cranial nerve number 8, you should be able to know. Cranial nerve number 2, just like that. Okay? So you need to be familiar with these cranial nerves. Okay? So let's start. So there are 12 pairs of cranial nerves. The first 2 cranial nerves, they are like extensions. They are not really true cranial nerves. They are basically extensions of the brain. They are extensions of the brain. The first one is called what? Olfactory nerve. Olfactory nerve. What is its job? What's the function? Sense of smell, isn't it? Sense of smell. Olfactory. Okay, olfactory nerve. Sense of smell. Then, second cranial nerve, optic nerve. Okay, function for vision or sight. Okay, for vision or sight. So we can see that these are basically extensions from the brain. Okay, more specifically from the forebrain. The extensions of the forebrain. Olfactory for the sense of smell, optic for vision. Then, and these are purely sensory nerves, purely sensory, okay, nerves. No motor aspect, just sensory, okay? Meaning that they carry information from the periphery towards the brain, okay? From the periphery towards the brain. You can smell the environment, okay? You'll be able to identify various substances, fish, chicken, what, okay? Vision, you can be able to see and so on. The third cranial nerve, we mentioned it, it's called what? Oculomotor nerve, okay, oculomotor nerve. What's the function of this nerve? For control of extraocular muscles. For now, we'll just say for control of extraocular muscles. But when you come to 40, you need to know which muscles are controlled by the oculomotor nerve. So for control of extraocular muscles, these muscles, they basically control the orbit. I mean the eyeball, sorry, the eyeball. So we have the eyeball in the orbit, okay? You can make it move up, down, sideways, okay? So we have nerves which control the eyeball movement. Okay, and the oculomotor nerve is one of them. Apart from that, it also controls the pupils, pupillary constriction, oculomotor nerve. Then, fourth cranial nerve is what? Trochlear nerve. Trochlear nerve. Okay, trochlear nerve. It's the only cranial nerve that exits the brainstem from behind. All the cranial nerve come out of the brainstem anteriorly, except the trochlea, which comes out from behind. Okay, so trochlear nerve. The trochlear nerve, again, just like the oculomotor, is for control of extraocular muscles. The next one is fifth, trigeminal nerve. The trigeminal nerve, as the name suggests, trigeminal. It has 3 divisions: ophthalmic, maxillary, and mandibular nerves. So it has ophthalmic, maxillary, and mandibular. So if you go like this, okay, so ophthalmic to the eye, maxillary to the maxillary region of the face, and then mandibular to the mandible, the lower jaw. Okay, so that is the trigeminal. Again, these divisions, ophthalmic is purely sensory, together with maxillary is also purely sensory to control, for sensation of the face, for sensation of the face, in the distribution of the ophthalmic and, do I have that picture? And maxillary region, okay, I don't have it. So you could see the, oh yeah, it's there. So you can see this, you can see the colors there. So any sensation from this green region will pass through the ophthalmic. Any sensation from this pink region, maxillary. And this one, mandibular. So ophthalmic, maxillary, purely sensory, but mandibular is both sensory and motor. Motor to control muscles of mastication, muscles which control chewing, for chewing muscles, to control those muscles for chewing. Okay? The next one, after trigeminal sixth, abducent or abducens, if you want, abducens, again for control of extraocular muscles. For now, we'll just say for control of extraocular muscles. But when you come next time, it's detailed. You need to know which muscle is controlled by the abducent nerve. Okay? The lateral rectus, for instance. Okay, then seventh is facial nerve. We mentioned it, facial nerve. The facial nerve is to control muscles of facial expression. Muscles of facial expression. Okay, we can tell whether you're happy or you're sad, frowning, so on, because of this facial nerve. Then the eighth cranial nerve is what? Vestibulocochlear. Vestibulocochlear nerve to control balance as well as hearing, sense of hearing. Okay? Vestibulocochlear. Vestibular part is for balance. Cochlear part is for hearing. Okay? So it's a two nerve in one. Just like we have three nerve in one for trigeminal. Then glossopharyngeal nerve is the ninth cranial nerve, glossopharyngeal. Okay? Glossopharyngeal nerve, various functions. But one of the functions is that it carries, for instance, taste sensation from the posterior one-third of the tongue, carries taste sensation from there. Also, the facial nerve also carries taste sensation from the anterior two-thirds of the tongue. Okay? Glossopharyngeal, together with the, it controls, some muscles of the pharynx. Okay? Stylopharyngeus, for instance. Okay? Stylopharyngeus, and so on. So for now, we want to go into the details. Vagus nerve, a well-known cranial nerve, is the longest cranial nerve. Okay, so it comes from the brain there, passes down to the thorax, into the abdomen. Okay, and so it can supply even the GIT all the way up to the splenic junction, splenic flexure of the colon. Okay, so the vagus nerve has a number of functions, including, for instance, control of respiration, control of heartbeat, okay, and it can control what's the reflex again? For instance, if someone wants to push an object into your pharynx, you get the gag reflex, okay, gag reflex. So if someone wants to push something into your to respond quickly to prevent that, okay, and we call it a gag reflex. Okay, so together with accessory nerve, cranial nerve number 11, okay, gag reflex control. So the vagus has a number of functions. There are a lot of them. Accessory nerve, the same gag reflex, and also for control of muscles. We have, for instance, the sternocleidomastoid muscle, as well as the trapezius muscle. So when you shrug your shoulders, okay, that's trapezius. When you look sideways, okay, sternocleidomastoid muscles supplied by the accessory nerve. Then hypoglossal is cranial nerve number 12 for control of tongue muscles. Okay, hypoglossal. So we can see from these various pictures. Okay. So you can see the vagus. If you look at the vagus, we can see to the pulmonary system, to the cardiac, okay, to the ear as well as the GIT. You can see this cranial nerve. Okay. So it carries important information. So we are done with the cranial nerves. You should know the cranial nerves. For you like chunking, I'm sure you find the various chunks as you study so that you can remember the cranial nerves. But the problem with chunking is that if you forget just one letter, then the whole system is gone. Really? Spinal nerves, 31 pairs. What is the arrangement? We have cervical nerves, which are 8, C1 to C8. Okay, cervical nerves. We have thoracic nerves, okay, 12. Okay, T1 to T12. We have the lumbar nerves, L1 to L5. We have sacral, S1 to S5, and we have the coccygeal nerve. So these are the spinal nerves. Okay, so they are named according to the level of the spinal segment. So we have got cervical. It means that these are coming from the cervical segment of the spinal cord. Cervical segment. Like this picture which highlighted. So you can see this green is the cervical part. Then we have the thoracic, we have the lumbar, the sacral and coccygeal. Okay. So for these ones, just know the way they are numbered. Okay. Cuda equina, I've already highlighted the cuda equina nerves. Okay, but maybe just in terms of the which ones specifically L2. You can say from L2 to coccygeal 1. So meaning L2, L3, L4, L5, and S1, and then CO1. Okay. So these nerves, they make up the cuda equina nerves. Okay. They make up the cuda equina nerves. When you paralyze them, you paralyze the body below the umbilicus. Okay. Yes, there's yeah. Okay. So yeah, so don't confuse it with the vertebra. With the vertebra for the vertebral column. So the vertebra, they are 7 cervical, but the nerves, they are 8 cervical nerves. Okay. So vertebra, we have C1 to C7. Okay, but the nerves, they are 7. Okay, so there's a difference there. Yeah. So don't confuse the vertebrae for the spine versus the spinal nerves. Okay. Then spinal nerves. This slide is just trying to show the epineurium, perineurium, endoneurium. That the same arrangement you have in the skeletal muscles. I'm sure we have done the arrangement of fibers in a skeletal muscle. Okay, each individual fiber is surrounded by what? Bundles are surrounded by what? The entire muscle is surrounded by what? You know those structures, huh? Each individual fiber, nerve fiber, what sheet surrounds it?
Perineum.
Huh?
Perineum.
Yeah? Endomesia.
This is a
Then
neuron, not
bundles,
a nerve. He's talking about a nerve. This is a neuron.
perimecia, and the whole
You said the nerve.
muscle. Yeah, so that same arrangement is the same arrangement also in a nerve. If you get a nerve, you will find that the fibers, they are arranged
Talking
like
about the
that.
neuron, right?
Like
Yeah,
that.
it's an egg.
Okay. Now we come to the typical spinal nerve. Typical spinal nerve. This one is a must. You need to know the typical spinal nerve. Okay, the typical spinal nerve arrangement. You can be asked to draw a well-labeled diagram of a typical spinal nerve, or you can be asked to label a typical spinal nerve arrangement. Okay, when you start your dissections, you find intercostal nerves, for instance, intercostal nerves. You must know those intercostal nerves. What are they, anatomically speaking? Okay. So, a typical spinal nerve has the following structure. Okay, this is one diagram. Okay, simplified version. Then we'll look at the other one. Okay. So now let's look at this one. So a typical spinal nerve is basically a nerve that is formed by two roots, fusion of two roots, the ventral root and dorsal root. So we have what we call the dorsal root and the ventral root. Dorsal root, you can also call it posterior root. The ventral, you can call it anterior root. These two roots, they join together to form a spinal, or rather to form a spinal nerve. So here at this junction, where it says trunk, that's basically the nerve, the spinal nerve. That's a segment for the spinal nerve. Okay? And we can see that the anterior root is this one. This is the anterior root, which comes from the anterior horn of the spinal cord. From the anterior horn of the spinal cord. Okay, this is the anterior root. And then we have the posterior root, which comes from the posterior horn of the spinal cord. Posterior horn of the spinal cord. This is a ganglion, a dorsal root ganglion. Okay, though not correctly illustrated here, it's supposed to be more like a pseudo-unipolar neuron type of arrangement, where it is supposed to have a stalk here, which comes out from the posterior horn and forms a ganglion. You get the point, huh? So let's see if should be. I don't think I have that. Okay, this is another picture. Though again not correctly shown. But anyway, what I'm trying to say is that it's supposed to be like a pseudo-unipolar neuron, because that's where you're going to find pseudo-unipolar neurons. So we're supposed to have a small stalk projecting from this posterior horn. You have a dorsal root ganglion. Okay, like that. But anyway, it's fine. So after these two fuse, they form the nerve. This is the nerve. From here to here, this is the nerve. That's the nerve, the actual nerve. Then the nerve now branches. The nerve branches to give what we call the rami. We have the ventral ramus and we have the dorsal ramus. So these rami, they come from the nerve. They come from the nerve. So you must be able to know where the nerve really is. Where is the nerve? When we say spinal nerve, where is it really? Okay, so the nerve is just that segment after the fusion of the roots before its bifurcation into ventral and posterior rami. Okay, before the bifurcation. So we have the ventral primary ramus and the dorsal primary ramus. Now this ventral primary ramus, as we can see, is bigger or longer than the dorsal primary ramus, because the dorsal is just coming to supply the structures at the posterior trunk. Okay? But the ventral one, it has to supply the lateral part of the body and also the anterior part. So you can imagine all this is supposed to be supplied by the ventral primary ramus. And then the dorsal goes to supply the dorsal aspect. Okay? So that's why this one is bigger compared to the dorsal. But again, we can see from the branching network that the ventral primary ramus comes to branch again to give a lateral cutaneous branch. Okay? If you have lateral, we have also, this lateral comes again to subdivide into pleural branch, muscular. This one is specifically a thoracic. It's at the level of the thoracic spinal nerve. That's why we are finding things like pleural branch. Okay, pleural branch to supply the pleura surrounding the lungs. Okay, you can say the anterior cutaneous branch. So the ventral primary ramus comes to divide into an anterior branch to supply the anterior part of the trunk, and also a lateral branch to supply the lateral part of the body, of the trunk. And then, whereas the dorsal, again, goes to divide into lateral and medial. So lateral to come to the lateral aspect towards the lateral, okay, and then medial to supply the more medial part of the trunk. Okay. Of note is attachment of the sympathetic ganglion. The sympathetic ganglion. Attachment of the sympathetic ganglion to the ventral primary ramus. Through what we call the white and gray ramus communicans. Gray and white ramus communicans. Okay, rami communicans. Ramus is what? Rami is plural. So white and gray rami communicans. Okay, so we have this sympathetic ganglion. What is a ganglion? I think we defined this last time. Huh? What's a ganglion? What is a ganglion? A ganglion is, yes sir. Sorry? Cluster of neurons. No. The neuron has a lot of parts. Yes sir. Cluster of cell bodies, okay, of neurons. Where? In the peripheral nervous system. Okay, that's a correct because a cluster of cell bodies can also be gray matter in the spinal cord or gray matter in the brain. Okay, so this is a collection of cell bodies of neurons outside the CNS or in the peripheral nervous system. Okay, so we can see here already we have two types here. We have the dorsal root ganglion and we have the sympathetic ganglion. Okay, so it's very simple to draw this diagram. Just draw a section of the spinal cord like that. Be able to show the gray matter divided into horns. We have the anterior horn, lateral horn, and posterior horn. So here we have just shown the two, the anterior and the posterior. But strictly speaking, the horns, there are three. If you look at this other one, there are three. So we have an anterior horn, we have a lateral horn, which is small, and then we have a posterior horn. So you draw a section of the spinal cord. The ventral horn the ventral root, ventral root, it will get the cell bodies from the ventral horn of the spinal cord. So cell bodies, which the neurons which pass through the ventral root, the cell bodies are in the ventral horn. Whereas neurons which pass in the posterior root, the cell bodies are in the posterior horn. Okay? So as we can see here, these are preganglionic neurons. Preganglionic neurons. Preganglionic neurons in the ventral root, they have their cell bodies in the anterior horn. Together with also, if we add now, the cell bodies of neurons in the lateral horn. In the lateral horn, they also pass through the ventral root. They also pass through the ventral root. Now these ones, they are special. These green ones here, these ones are special, which come from the lateral horn. These are the ones which form the sympathetic, the autonomic nervous system. These are the ones which form the autonomic nervous system. So when we say sympathetic outflow is T1 to L2 spinal segments, okay, it means that the neurons which come from the lateral horns of the spinal segments T1 to L2, they form the sympathetic nervous system. Okay, and they pass anteriorly like this. Okay, in the ventral root. Why pass in the ventral root? Because the ventral root is for motor fibers. The ventral root is for motor fibers. Okay, fibers from the CNS to the periphery. Whereas fibers from the periphery to the CNS, those are afferent, they are sensory. So you have to use the posterior root. We get the point? Remember, we divided the PNS into afferent, efferent. Afferent, we said these are sensory fibers. Efferent, these are motor fibers. What do we mean by sensory? Sensory, they are carrying impulses from the periphery to the CNS. What about motor? From the CNS to the periphery, away from the CNS. So the fibers which carry impulses from the periphery to the CNS, they have to use the posterior root. Whereas those from the CNS to the periphery, they have to use the ventral root. So the ventral root is motor, whereas the sensory root is, the posterior root is sensory. Okay? Those are MCQs. Yeah, so we need to know that. So that's why we can see here these fibers. So after these roots join, this is the spinal name. This is the name. Then it bifurcates to give the dorsal primary ramus and the ventral primary ramus. And we can see the sympathetic ganglion attached to the ventral ramus through the white and the gray ramus, gray rami communicans. You can see the gray ramus communicans there. You can see the white ramus communicans there. To the sympathetic chain, okay? The sympathetic ganglion. Okay, any questions so far? Because now this one is a must. If you are not paying attention, you better now pay attention. Because the typical spinal name is a must. This one you have to know it in detail. You can generate 20 questions just on the typical spinal name. Yes, sir.
Let's pause. Because you can't cover it. This will be just 2 hours. I didn't finish.
Yes, so it could be variation. So So variation is possible between individuals, anatomical variation. Okay, so I've highlighted the roots. Okay, so this discussion, you must focus on the roots, where they are coming from. Okay, and then the nerve, the spinal nerve, I was also highlighted. So I've said that for the roots, we have two roots, ventral, posterior. The ventral root carries preganglionic fibers from the anterior horn as well as the lateral horn. But the fibers for the lateral horn, those are autonomic fibers. Whereas the fibers for the ventral horn, those ones, what do you think? These ones are what? They are motor to skeletal muscles. Huh? These pink ones. The pink ones here from the anterior horn of the spinal cord, anterior horn cells of the spinal cord. Those are motor to skeletal muscles. For autonomic, it's from the lateral horn, the green ones. Okay? So those are motor to the cardiac muscle, smooth muscle, glands. Those ones. That's why they have to go through the sympathetic chain. That's why they have to go through the sympathetic chain. Okay? On the posterior root, know the dorsal root ganglion. Know the dorsal root ganglion. Okay? So dorsal root ganglion, just basically a collection of cell bodies of neurons, sensory neurons passing in the dorsal root. Know the position for the actual spinal nerve. The actual spinal nerve is formed by formation, or rather fusion of the dorsal root and the ventral root. When they fuse, they form the nerve. Now that nerve then bifurcates to give dorsal primary ramus and ventral primary ramus. The dorsal is to supply the dorsal aspect of the trunk, whereas the ventral comes to supply the anterior aspect as well as the lateral aspect of the trunk. Now, if I may ask, the limbs, upper limbs and lower limbs, which nerves or which branches of the nerve, which rami supplies the limbs? Which rami? Is it the dorsal primary ramus or ventral primary ramus? Yeah. Dorsal, ventral. Yeah, so ventral, the majority wins. So it's the ventral. So these limbs, they are supplied by the ventral rami. Okay, ventral rami, because they are in the lateral aspect of the body. Okay, they originate from the lateral aspect of the body. So we expect that the nerves which come to supply the limbs, they come from the ventral rami. They come from the ventral rami. So if you hear of, for instance, the median nerve or musculocutaneous nerve, or let me just say brachioplexus. The brachioplexus nerves, they are basically branches from the ventral rami of the nerves. Okay? Of the nerves. Okay, C5 to T1. So, yeah, so that's important to highlight. Then after the bifurcation, remember again that you need to go and bifurcate these rami. So the ventral ramus comes and then gives an anterior branch to supply the anterior aspect and the lateral branch to supply the lateral aspect. Those can also further go and bifurcate depending, okay, on the area of distribution. The same applies for the dorsal ramus. It also comes out and branches into the medial and lateral branches. Okay? Then now, you need to attach the relationship of the sympathetic chain with the ventral rami. Okay, so we have this is the sympathetic ganglion, which is attached by the communicants, white and gray ramus communicants. Okay, and we can see here these are the communicants. Now, what is the key information here in the communicants? What you need to know is that these communicants, they contain sympathetic, or rather they contain autonomic fibers. They contain autonomic fibers, and these autonomic fibers from the lateral horn of the spinal cord, they come through the ventral rami into the nerve. The nerve, they come to the ventral ramus. From the ventral ramus, they come to the sympathetic ganglion through the white ramus communicants. That's how they enter into the sympathetic ganglion. They use the white ramus communicants. They don't use the gray. They use the white. So even when you are drawing this diagram and then you show the autonomic nerves, then instead of labeling this as white, you label it as gray. You are wrong. Immediately, that's zero. Because that's not where they enter into the ganglion. They use the white ramus communicants to enter the sympathetic ganglion. And then to exit this, okay, to exit the sympathetic ganglion out, of course, there are various possibilities. What are the possibilities? So when the autonomic fibers come like this, in this case, we are talking about sympathetic nerves. In this case, we are talking about sympathetic nerves. When these nerves come to the sympathetic ganglion, there are, I think, three options. Okay? The first option, in fact, 4 options. The first option is that the nerve may decide, the neuron, not the nerve, the neuron may decide not to synapse. Not to synapse at this level. It can decide to pass through the ganglion at that same level minus synapsing. Have we seen that? This one here, it has come straight, passing through the sympathetic ganglion at that same level. Let's say this is a T1. At the same T1 sympathetic ganglion, this neuron has passed through the sympathetic ganglion minus synapsing, and it has come to supply various structures here. We call such a neuron a splanchnic neuron, a splanchnic nerve. Nerve, remember, is a collection of neurons. So here we can call it splanchnic nerve because it has got a number of neurons inside. Okay, so in case you are asked, what is a splanchnic nerve? What is a splanchnic nerve? What would be your definition? Splanchnic nerve. Remember, a nerve contains neurons, isn't it? So all you need to do is know what type of neurons are passing in that nerve. Know what type of neurons are passing in that nerve. So in this case, these are they somatic nerves? Neurons? No. These are autonomic neurons. So a splanchnic nerve is a nerve that carries autonomic neurons that pass through the sympathetic ganglion minus synapsing. Pass through in fact, we can even call these as paravertebral ganglia, because I'll show you the pictures. So either paravertebral, or you can even just say sympathetic ganglia minus synapse. So it just pass minus synapse to supply structures. Okay? So they are carrying autonomic. The key is autonomic neurons that have not synapsed. That's the key. They haven't synapsed. That's one option. The second option is that the neuron can come, if this is T1, this neuron can decide either to ascend up and go and synapse at a higher level. So if it's T1, it will come to T1, yes, but it won't synapse, and it won't come out from the sympathetic trunk. It will just ascend up to go and synapse maybe at C3, sympathetic ganglion. That's where it's going to synapse from. Instead of at T1, it goes up to synapse at, let's say, C3 ganglion. We get the point? That's why you can explain to say why we are saying sympathetic outflow is T1 to L2 of the spinal segment. But how come we can find the sympathetic nerves in the head and neck? How? How come we have sympathetic nerves in the head and neck region when we expect the lumbar, or rather the sympathetic trunk, to be from T1 to L2, isn't it? That's what we are saying. But we find the sympathetic nerves in the head and neck. How? It's because when the neurons are coming like that, some of them are sent up the sympathetic trunk all the way to go and synapse at the higher level and distribute the fibers. We get the point?
Yes.
That is second option. The third option is that the neuron can decide to descend down. Minor synapsing at T1, in this case, we'll give you an example, T1.
I'm not really sure.
Minor synapsing at T1, it can decide to descend and go and synapse at a lower level.
No.
Let's say it goes to synapse at S2. That's the third option. The fourth option is that it can synapse at the same level, like in this case. If this is T1, it can synapse at T1. But when it synapses, remember, synapses, the post-ganglionic neurons. And remember that in that definition for splanchnic nerves, you have to emphasize that the neurons are pre-ganglionic. These are pre-ganglionic autonomic neurons that pass through the sympathetic ganglion minus synapse. They are pre-ganglionic neurons. Now, after they synapse, we have post-ganglionic neurons. Now, post-ganglionic neurons, if they are not going to be splanchnic, like in this case here, then they have to use the gray ramus communicans. They have to pass through the gray ramus communicans to go and supply, for instance, the sweat glands, the erector pili muscle in the skin, to go and supply the skin. Those are post-ganglionic fibers now. Post-ganglionic fibers to go and supply the skin, structures in the skin. So, that is how come those sweat glands, those are glands, they are controlled by autonomic system. Glands, autonomic. Smooth muscle, erector pili muscle, for instance, is smooth muscle in the skin. So, supplied by these autonomic fibers. Okay, cardiac muscle supplied by these splanchnic nerves, thoracic splanchnic nerves to supply the heart. Okay. So, And also, of course, the smooth muscle of various structures in the abdomen, the GIT and so on. Yeah. So that is the autonomic fibers. So when you look at this picture, it's showing you components of the autonomic system and components of the somatic system. The somatic to supply skeletal muscles, these pink ones. They are coming to supply skeletal muscles, as we can see here. Supply skeletal muscles. Then we have the sensory ones, which pick information and sensory impulses pass through like that to go to the posterior root, to go to the CNS, okay, dorsal horn of the spinal cord. Okay, so that's that. Now, this is just separation for you to understand, for you to easily understand. Otherwise, we could have used just one side to show all these neurons. Could have used one side, but we have just separated them for easy understanding. But otherwise, these ones also could have been here, and then we distribute them in this same picture on this side, showing you that a nerve, if you get a nerve like this one, a typical spinal nerve, if you get this nerve here, you analyze the fibers in that nerve. What are the different types of neurons which are present there in terms of functional classification? We did the classification of neurons, huh? Yes. In terms of functional classification, in that bundle, you are going to find some are sensory in general, some are. So if you are going to classify, they are just going to say, you do two divisions: sensory, motor, isn't it? Sensory and motor. Now, the sensory, we can see those blue ones. The sensory, we have sensory fibers from somatic structures, okay? From somatic structures, and also you can have sensory fibers from visceral structures, like intestines. They also feel pain. Don't think that the pain will only be from the skeletal muscles. No, even in internal structures, they feel that pain. Kidneys, intestines, and so on. So the fibers which pick sensory pain sensation from visceral structures, we are going to call them sensory visceral fibers. Sensory visceral. Okay? So, or we can call them general somatic afferent for general sensation, and we can call them general somatic efferent if you want. Afferent for sensory, efferent for motor. In short here we are saying general somatic sensory, general somatic motor. Now, it means you have general sensory fibers and you have somatic motor fibers. Then now you go further, you say these are just somatic nerve fibers. Somatic nerve fibers, meaning these fibers are carrying sensation from somatic structures like skeletal muscles. A skeletal muscle should contract. That is somatic motor. A skeletal muscle should be able to feel pain. That is general somatic afferent. Okay? Then now you come to the visceral structures. The visceral structures also, instead of somatic nerve fibers, we're going to call them autonomic nerve fibers. autonomic nerve fibers. Again there, we have those which carry sensation, and we have those which carry motor. So we have general visceral afferent, which is visceral sensory fibers. We also have visceral motor fibers. So when you cut a nerve, like that, that nerve has a lot of fibers, and you need to classify those fibers there. We have those which supply somatic structures. We have those which supply visceral structures. Somatic structures, motor, sensory. Visceral structures, motor, sensory. You get the point? So that is the classification of the fibers in a spinal nerve. It means you have grouped these various fibers in one nerve. You have grouped these various fibers in one. So you have this one has come here. So the blue ones are there, the red ones are there, the green ones are there. But don't forget that the sensory ones, we have those which are sensory from visceral structures. These are more like autonomic structures. Okay? And then we have those in the skeletal muscles. So that's why we're saying somatic sensory and visceral sensory. Okay? Somatic sensory, visceral sensory. The same way again, opposite direction, somatic efferent or somatic motor, and also visceral motor to supply visceral structures. Any questions on the typical spinal nerve? Now, when you come to dissection of the thorax, you find these intercostal nerves which run in between the intercostal spaces. These, what do you think? These are what? To ask this question, huh? These are primary, coming from primary ramus or dorsal ramus? From ventral or dorsal ramus? From ventral, okay? So this is a picture to show you the intercostal nerve. Okay, so this is the intercostal nerve, this one. Running together with the vessels, veins and arteries. So you can see that here we have a dorsal root, ventral root. They unite, they form a nerve. The nerve bifurcates. This is a dorsal primary ramus, okay, which branches there, and there. Then we have the ventral primary ramus. Now this ventral primary ramus is basically the intercostal nerve. Which comes now to divide, okay, into lateral and anterior branches to supply these structures. Okay, so that's that. A dermatome, you should know that a dermatome is just basically an area of skin supplied by a single spinal nerve. So for instance, these are dermatomes. So when you come across such pictures, it's just showing you dermatomes. Okay? That at this level, what dermatome do you expect at the umbilicus? What do you expect at the nipples? What do you expect at the clavicles? And so on and so forth. So as you test the patient, you can know the level of sensation.
Break, baby.
Let's finish.
Break, 9 minutes.
Let's finish. Yeah, So at this diagram, just showing the dermatomes, okay, just showing the dermatomes, okay, you can know what level you are at, okay, if you test the patient. Let's say you give a spinal anesthesia, you give a patient spinal anesthesia here, and then you want to assess whether you have a high spinal or not. You can assess at the level of the umbilicus, you can prick the patient there. Are you feeling pain? No, yes, no, and so on. You go to the area of the nipples. Are you feeling pain? The patient should feel pain at the area of the nipple when you have given anesthesia. If the patient doesn't feel pain, it means that area is also paralyzed. And now it's a high spine, because at the nipple we can see there, the level is like T4. It means you have gone higher up. In case of, there's a table here to just show the important dermatomes. So at clavicles, C5. At the umbilicus, T10. Okay? At the nipple, T4. Perineum, S2, S4. Something like that. Just key dermatomes. Okay, so now we have come to autonomic nervous system. This is the last part.
Okay, let me drink water. Sir, drink some water.
Break between physiology and anatomy and the brain. Did you have a break?
No.
I met the gentleman outside. He was like, no, we are tired of waiting. It means you have been waiting for a long time. So anyway, don't take time, just 2 minutes we conclude. Okay, so autonomic nervous system. So of course, these are things we have already said. So sympathetic system, parasympathetic, we know. Maybe here, just to highlight, is the S2 to S4, S2 to S4. So this S2 to S4, which is here, we can see here, this is S2 to S4. Okay, supplying various structures. Parasympathetic is supplied to the large intestine, blood, and so on. What you need to know here is that the S2, S3, S4, they pick up where the vagus ended. Where the vagus, this is cranial nerve number 10. You can see that the vagus nerve goes all the way to supply even the intestines to the level of the splenic flexure of the colon. This is where the vagus will end in terms of, if you follow the GIT from the mouth to the anus, up to the large intestine, at this corner here, where the spleen is, this side. This is where the vagus ends its function, because that's where it terminates in terms of GIT. And then now, this S2, S3, S4 pick up now from there all the way up to the anus, okay? Including pelvic organs like the bladder, the uterus, okay? The testes. So all these, okay? So we call these nerves the nervi irrigators, okay? Nervi irrigators. So these are the pelvic splanchnic nerves. Pelvic splanchnic nerves, S2, S3, S4. Nervi irrigators. They are preganglionic. Remember, they are splanchnic, so they are preganglionic as well. But in this case, parasympathetic instead of sympathetic. They are parasympathetic. And they supply the hind gut from the junction of the proximal 2/3 to distal 1/3. That's the splenic flexure. And then urinary bladder, internal urethral sphincter, and the external genitalia, like in erectile tissues. Okay, so all these are supplied by the pelvic splanchnic nerves. Okay, we have already highlighted the communicants. Why is it called gray? Because it appears gray. Why? Because the fibers, they are unmyelinated. Most of the fibers, okay, they are unmyelinated, so it appears gray. The other one is white because of myelin sheath that surrounds neurons, so most of those fibers are myelinated. Now, the sympathetic system has this so-called sympathetic chain. You can see this. It's a sympathetic chain which has those sympathetic ganglia. Okay, sympathetic ganglia distributed from cervical region all the way up to the ganglion impa, there. Okay, there's an arrangement there. Okay, we can see there. So this is the sympathetic trunk. Okay, so that's why I'm saying that a sympathetic neuron can be here, but it can go up and synapse at a higher level of ganglion. It can go up or down or at the same level, okay, or passes through minus synapse. And those which pass through, they form sympathetic splanchnic nerves, okay, which group together and form the thoracic splanchnic nerves, greater splanchnic nerve, T5, T9, lesser splanchnic, T10, T11, and the least splanchnic, T12. Okay. These two slides, just the physiological functions of the sympathetic and the parasympathetic. So that's your but this is physiology. Don't spend much time there. That's physiology. Which other one did I want to highlight? Yeah, the other one I wanted to highlight is the parasympathetic ganglia. Parasympathetic ganglia. Where is it? Parasympathetic ganglia. We have specific parasympathetic ganglia. Where is that? We have specific parasympathetic ganglia. We have specific parasympathetic ganglia, peripheral ganglia, okay, which have sympathetic, parasympathetic, not sympathetic. Sympathetic is that chain, okay, but for parasympathetic, we have 4 ganglia, okay. We can see the names: ciliary ganglion, okay, the otic ganglion, the submandibular ganglion, and the sphenopalatine ganglion. So it means parasympathetic fibers, that's where they go to synapse parasympathetic ganglia. Those from the oculomotor, facial, glossopharyngeal vagus, together with the, so those, they go and synapse in these ganglia. They don't synapse in the sympathetic chain, no. They synapse in these ganglia. Okay, to the eyes, ciliary ganglion. To the submandibular and sublingual salivary glands, submandibular ganglion. Sphenopalatine, lacrimal gland. Nasal and palate, mucosa. Otic ganglion, parotid salivary gland. Okay? So again here, be familiar with these ganglia. Be familiar with the parasympathetic ganglia. Okay, you can be asked which of the following is a parasympathetic ganglion, or which of the following is not a parasympathetic ganglion. Last now is the enteric nervous system. Remember, I mentioned to say this one is a separate one from the general classification, so it's purely in the GIT. Okay, and this system basically consists of the nerve plexuses, which are 2. We have the